depending on how the discussion goes. And then there is also another case that Indraja has seen. So we can ask her to present it short case as a short case. She probably doesn't have a presentation, but that's actually good because in the exams you don't get a presentation. You have to do it extempore. Okay. Right, Pavan. So you start doing the present. Indraja?
Yes, sir.
You are ready with the presentation, no? If you need
Yes,
to
sir. I made the PPT, sir.
Okay, right. In case it is we finish this one, you can share that, and then it'll be a nice compare and contrast. Okay.
Okay.
Right.
So can I start, sir?
Yeah, please.
Good evening, everyone. I am Dr. Pavan Kumar, third year DNB resident from Sagar Hospitals. Welcome to today's case discussion. "18 years male student."
Just a minute, Pavan. Are there any other teachers in the thing? Is Srikanth there?
No, sir.
No, sir.
No teachers are there, no? Only me.
Yes, sir.
No,
Okay.
nobody is there.
Okay, fine. Niranjan, you had informed him?
Yes, sir. Sir, no, sir. Today case.
Okay, right. Okay, start presenting.
18 years male student who is a resident of Hassan came with the complaints of swelling in the neck since 3 months. Patient was apparently normal 3 months ago. Then he noticed a swelling in the left side of the neck, which was insidious onset, which was initially smaller in size, around 2 centimeters, with recent increase in the size of the swelling in the last 1 month. The swelling was not associated with pain. There was no history of difficulty in swallowing, breathing, change of voice, no history of fever with night sweats, cough or hemoptysis, no other swellings in the neck, and no history of ear pain, difficulty in neck movements, and no history of loss of weight or loss of appetite. There was no history of similar complaints in the past, and no history of previous surgeries, no history of radiation exposure, and no medical comorbidities. Patient is a non-vegetarian with a normal sleep pattern, no altered bowel and bladder habits, and he is neither an alcoholic nor a smoker.
Pavan,
yes, sir.
I told you so many times.
Yes,
I don't think you should use the word alcoholic unless the patient is actually an alcoholic.
Okay,
if
sir.
a patient is consuming alcohol every day beyond a certain set limit, then you label them alcoholic.
Okay.
So I think you better not say that word at all. Just
Okay.
irritates many examiners. So you just say does not consume alcohol.
Alcohol. Okay, sir.
Okay, right.
Yes, sir. And he is not allergic to any medications, and there was no relevant treatment history. Family history was not significant. To summarize, an 18 years old male complains of painless swelling in the left side of the neck with recent increase in the size last 1 month.
Okay, stop here. See, the family history,
yes,
you
sir.
should say not significant, not significant, but say not contributory.
Okay, sir.
Because what is significant for you may not be significant to somebody else. But
okay, sir.
Contribution can, it's a more kind of definitive word. For example,
okay,
if there is somebody in the family with breast cancer and this lady has developed breast cancer, then the family history is contributory.
Okay, sir.
So you use the word.
I joined recently. Painless swelling since how many days?
Namaskara, Guru.
Namaskara.
Sir, since 3 months, sir.
Where you are not mentioned here?
No, here in the summary he has not mentioned, but he should have. But
any other symptoms?
No other symptoms, sir. So no pain, nothing, sir.
Okay.
See again.
Yes, sir.
I always, I don't know the other. Huh?
You should not book plates.
Sorry.
How the other examiners will react, but I always think, see, even as a doctor, I don't know, Srikanth may also, agree with me. Even as a doctor, if you notice a swelling, most of us may have one swelling or the other somewhere. We don't go around measuring it. we
Okay.
don't put a tape measure and say this is 3 centimeters or what. So you said the swelling is 2 centimeter in size to begin with. He's a, small, sort of, he's a youth from, district headquarters of Hassan is a city, but still you wouldn't expect him to, measure his swelling. So nothing is lost unnecessarily by creating controversy by saying, you just say swelling was small to begin with and it gradually progressed to the current size. You don't mention any measurements in the history because unless the patient has specifically measured it and told you it was 3 centimeters and now it has become 5 centimeters, then you can say, and if the examiner asks you, you say, yes, the patient did actually, measure it and told me. Otherwise, you can say the swelling was small to begin with and gradually increase in present size to present size. And also you should, specifically mention has there been sudden increase in the size. Because if you look at the size of the swelling on clinical examination, it is fairly big. It is difficult to expect that to be a very small swelling, which has become so big in the last 2 months or so. So I think, these measurements are all subjective and flawed. So I wouldn't, sort of mention any size specifically. Okay. So that is a very scientific argument. I don't think anybody who actually expects you to say the size in terms of centimeters has any argument against what I've just told. In England, they like to measure it, size of a lemon, size of a whatever, apple or whatever, orange or whatever it is. But I don't think Indian examiners expect that. Srikanth, what do you say? Hello?
Yeah, totally agree.
So,
So since 3 months, there was no increase in suddenly it is increased, is it?
Yes, sir.
What was the initial size?
Sir, initially it's a small swelling, he said, sir.
What is small?
Sir, he showed little small.
So 2 months no increase and suddenly it increased.
Suddenly it increases, sir.
Okay.
anybody, Sania, is there anything you want to ask?
No, sir. I think you covered everything in history.
Abdul?
Sir is in journey, sir.
Huh? Where is he going?
Sir is
Some
traveling.
convocation with the brothers.
Okay, 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 right. Fine. So anybody else has any questions to ask Pavan? Okay, fine.
Sir, initially it is gradually progressive, Pavan. Like,
Actually, he noticed the swelling. Once the swelling becomes noticeable, then only he said it is increased. So past 1 month, it got increased, he said.
How many centimeters it increased in 1 month?
Sir, he didn't measure, sir. He said it increased to this current size, sir.
Okay, right. Go to the examination. Come on, man, Pavan. What's
Yes, sir.
happening? Go to the examination.
System got stuck. Yes, sir. So on general examination, after taking informed consent from the patient, patient was examined under adequate light and exposure, and patient is conscious and oriented and moderately built and nourished with BMI 21.8 and his Karnowski performance score 90% and ECOG score 1. There was no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, and pedal edema. His vitals pulse rate 82 per minute measured in the right radial artery with regular volume and rhythm. BP 110/70 mmHg in the right arm measured in supine position, and respiratory rate is 18 cycles per minute, and he was afebrile. On inspection, a swelling of size around 6 into 5 centimeters on the left side of the neck, which is 3 centimeters below the mandible, 1 centimeter above the clavicle, horizontally around 6 centimeters laterally from the midline, beyond the posterior border of the sternocleidomastoid, and the surface of the swelling appears smooth, and skin over the swelling was normal. The margins of the swelling are ill-defined and it does not move with deglutition, and no other visible swellings was noted. And swelling remains same on contraction of deep fascia, and there was a scar which was recently done biopsy site, and there was no sciences, ulcers or dilated veins, and trachea appeared shifted to right side.
Okay.
On
Continue.
palpation, yes, sir. Can I continue, sir?
Yeah.
On palpation, there was no local rise of temperature and tenderness over the swelling, and swelling of size 75 centimeters, palpable in the anterior triangle of the neck, extending posteriorly and extent as explained in the inspection. And the surface of the swelling is smooth and firm in consistency, and skin over the swelling was pinchable, and it is not mobile in horizontal and vertical planes and non-pulsatile. The trachea shifted to the right side and bilateral carotid pulses was felt on both sides, and no palpable lymph nodes in the neck. On auscultation, there was no audible bruit and movements of the neck was normal. Examination of the oral cavity was normal and examination of spine was normal.
Go to the inspection.
Yes, sir.
From the midline, you are telling 6 centimeter laterally. From the
Yes, sir.
midline.
Yes, sir.
Then how it becomes lateral swelling?
Sir, I took boarding landmark from the midline.
Huh?
6.
No,
Yes,
you are
sir.
telling lateral swelling of the neck, you are telling.
Yes, sir.
Then which lateral swelling extends up to the midline?
B.
No, but there is an answer to that.
Sir, thyroid or any lymph nodal swellings?
Yes, thyroid. What is that called? When it is large, it is in the lateral area, but then may come up to the midline.
Sir, latent aberrant thyroid, sir.
Lateral aberrant thyroid, yes. What is lateral aberrant thyroid?
Sir, actually, it is a palpable lymph node which is a mets from the occult primary papillary carcinoma of thyroid.
Okay. So lymph node mass can also start laterally, but then may come to the midline if it is a large mass.
Yes, sir.
Otherwise, usually not.
Okay,
So
sir.
this one, do you think this is starting in the midline coming laterally or other way around?
Sir, actually, it is other way around, sir. Some from posteriorly, I am thinking.
And it's coming up to the midline or 6
Yes.
centimeters from the midline.
Yes, sir.
Would you make out the posterior border?
Sir, borders are not clearly defined, sir. So I'm not able to feel the regular borders, sir. Ill-defined, sir.
That is in inspection. And how can you feel?
On inspection, can you make out, go to the next picture?
How do you put the deep fascia into contraction? Then
Sir,
Next,
by
next.
asking by asking the patient to flex his neck against the resistance, sir. So make the both sternocleidomastoids to contract.
that you are putting the sternomastoid into contraction, not the fascia.
Sir, sternocleidomastoid.
Pressing the mandible against swelling, we are putting both the sternomastoid into contraction.
Yes, sir.
How do you put the fascia into contraction?
Anybody else? Sanya? How do you put the fascia into contraction?
That is the same thing, so by asking them to flex the neck against contraction. Since sternocleidomastoid, it is invested by the same layer that is the deep fascia, sir. That also undergoes contraction, is what I had read, sir.
Correct. But you can also just hyperextension of the neck can also put the deep fascia into contraction.
Hyperextension of the neck is the correct answer.
Okay.
You are not
Okay.
putting, by flexing the neck, you are relaxing the fascia, no?
Okay, sir.
Hyperextension of the neck. For sternomastoid, what you said is correct. If you ask the patient to press down the neck against resistance, then you put sternomastoid into contraction.
Okay, sir.
Okay.
Lateral
There is-
swellings, do you tell the plane deep to sternomastoid or deep to fascia? Are the lymph nodes deep to sternomastoid or superficial to sternomastoid?
Sir, deep to sir.
Huh?
Deep to sir, deep to deep fascias.
And then it is superficial to sternomastoid, is it?
No, sir.
There is a question in the chat box by Sriram, Dr. Sriram. You had asked whether we should quote the Karnofsky score and the ECOG score. If you are thinking about a benign swelling, benign condition, then you need to quote the Karnofsky score. If you are thinking about a neoplastic condition, then you quote the ECOG score. Sometimes that differentiation is not possible. In that case, you can quote both. And if the examiner objects to it, you can say initially it was not obvious what it was, or the differential diagnosis includes both benign and malignant conditions, and hence I have quoted both. I don't think they will catch you on these things, but that is probably the most sensible way of handling it. Okay, carry on. This one, Nikita, you said clenching the teeth. Nikita?
Yes, sir. Regarding the fascia, like, sir, to stress the fascia, can we ask them to clench the teeth or jaw, sir?
How? And how will it contract the deep fascia? It won't contract the deep fascia. You are going to contract the masseter and those muscles.
So
the
in this
clenching-
case, why you want to put both the sternomastoid into contraction? The swelling is on one side, no?
Sir, but the swelling is coming from the which plane we have to know, sir. That's why.
Which test you do for this?
Sir, that's what's a deep contraction of deep fascia, sir. As you said.
No, Pavan, he is asking a very specific question. If you want to put one sternomastoid into contraction, what
Okay,
do you
sir.
do?
So, sir, ask the patient to turn to the opposite side, sir, by
Against resistance.
against resistance.
The
Very
lymph,
simple.
anyway, the lymph nodes will be deep to muscle or deep to fascia or superficial to muscle.
Sir, deep to muscle, sir.
Then whether you should put the muscle into contraction or fascia into contraction.
Sir, actually, muscle, sir. Muscle.
Deep to deep fascia, you will tell in the thyroid swelling, middle in thyroid swelling.
Okay, sir.
Okay. Carry on.
Sir,
Yeah,
hello, sir.
yeah.
Sir, in this case, sir, plane of the swelling, like it is still same even after contracting the muscle, sir. Like, generally, if we tell like if it is less prominent, that is then it is deep to deep fascia. Then what to mention here, sir, in this case?
I have not seen the case. I have not actually examined the patient. I have only seen the photograph. So, Pavan,
Sir,
is this swelling deep to the deep fascia or deep to the sternomastoid or superficial?
sir, actually, after contraction of the sternocleidomastoid and also deep fascia, the size of the swelling is same, sir, even after contraction, sir.
So, what does that infer? What do you
Sir,
infer from that?
maybe it's adherent to the surrounding structures, sir.
Should be specific. How can you say, then you will get stuck. What are the surrounding structures?
Okay, sir.
I have not examined, so it's difficult for me to say what is the plane of the swelling. Srikanth, what do you think?
No, what it is reducing and putting into the patient contraction, is it?
No, sir.
It is remaining the same, they are saying.
Then the swelling should lie on the fascia. If it is deep to deep fascia, then if putting in the patient contraction, the swelling size should reduce.
Reduce, yes, sir.
And same with the sternomastoid. So it's
Sternomastoid also.
probably arising from the fascia. Okay, that is the inference you can make.
Then
Okay,
you are going to get stuck there. Which structure you get superficial to fascia? Won't get any structure, man.
Okay, sir.
so you
The
should say there
examination,
is,
if your examination is wrong.
so you should say there will be, at least if there will be marginal decrease in the size of the swelling, if not very obvious.
Okay, sir.
As you say, if it is infiltrated the fascia from inside, then maybe it
It
may
has
not,
to reduce if it is deep to muscle.
yeah, it has to reduce. If it is infiltrating, then it may not reduce as much as it would have
Yeah.
normally. That's all. So there will be some reduction in the size of the swelling. But we have not examined, so we can't tell,
Lateral
definitely.
neck swellings, you should not tell fascia. Only midline swelling, you should tell fascia plane.
Okay, sir.
Because there is nothing in front of the fascia in the neck. Our only pretracheal muscles are there.
So laterally, as you said yourself, the fascia splits to enclose the sternomastoid. So you don't talk about the fascia there. You
There's
talk
no
about the
space
muscle.
between that.
So you
Okay,
talk about the muscle. Okay,
Okay, sir.
right. So the swelling is about what? 6
Oh, show
inches?
the palpatory findings.
Palpatory findings.
Yes, sir.
7 into 5 centimeter swelling in the anterior triangle of the neck, extending posteriorly, and firm consistency. Skin is pinchable, not mobile, or this one. So it is. So that gives you an idea
And
that
again, you palpation, you tell the plane of the swelling, no? Where you have to tell the.
Sir, I didn't get it, sir. Can you repeat once?
Yeah, you didn't say what is the plane of the swelling by in the palpation.
Sir, in
Yeah.
inspection,
Palpation, where is the finding?
sir, I mentioned that swelling size remains the same both on contraction of the deep fascia, sir. I have to.
That is an inspection, man. What about palpation?
Sir, sorry, sir. I have to mention there.
You should tell plane of the swelling, not skin is pinchable.
Okay, sir.
Work the palpation. Yeah, skin over the swelling is pinchable. That is not the correct sentence. You should tell what is the plane of the swelling.
Okay, sir.
Okay, it's an immobile swelling, so probably fixed to the undersurface of the deep fascia or the sternomastoid, and so hence it becomes less prominent on contraction of the sternomastoid.
Where did you feel for the carotid pulses?
Sir, between the trachea and the anterior border of the sternocleidomastoid, sir, at the upper border of the thyroid cartilage, sir.
Upper border of thyroid cartilage.
Yes, sir.
Get carotid there. Against what structure you feel the carotid pulse?
Common carotid artery.
Against what structure?
What structure?
Sir, C7 vertebra, sir.
E7 na? C7 you get subclavian artery.
C6, sorry, sir. Sorry,
No,
sir.
you don't say whatever you like.
Sir, let's say.
You have to feel against the transverse process of the second cervical vertebra.
C2. Okay, sir.
See, you're
If
saying.
you don't know, you please tell don't know. Don't get stuck and
How can you say
failed there.
C7, man? C7 is almost the end of the neck, no?
Lower end of the neck.
How can you say C7? you are palpating it almost at the upper part of the neck, right?
Okay, sir.
C2.
E7 it comes in the supraclavicular fossa.
So transverse process of the C2 vertebra.
Okay, sir.
Clear for
If you don't
everybody?
know, please tell don't know in the exams. Don't get beat around the
Somebody-
bush there only. They will not
Somebody
proceed
had
further.
put somebody has put the C6. Who was that? On the chat. I'll just see. Aishwarya. Aishwarya, it's not C6, ma. It is C2. Okay. Followed?
Yes,
Please answer.
Yes, sir. Yes.
Yes, sir.
Okay. Right.
Trachea shifted to right on inspection. What sign is that?
Sir,
What is that sign?
uh, I don't think so.
Trachea is what? How do you say trachea shifted to right on inspection? What?
That some
Someone
not
has put on the chart. You see. What is trail sign? You are final year or first year?
Sir, finally, yes.
ಏನಪ್ಪ ಗುರು ನೀನು ಹಿಂಗ್ ಮಾಡಿದ್ರೆ
Trail sign, man.
What is trail sign?
Sir, a trachea shifted to the
How do you do that? How do you do? How do you
Sir.
examine?
Sir,
Where do you stand? How do you examine for the whether
the
it's
examiner should be stand in front of the patient, and the patient is in sitting position, sir. So the ring finger and the index finger are placed over the tubercles of the clavicle, and with the help of middle finger, we have to palpate the trachea, sir, along this, and we will feel the any resistance between the sternocleidomastoid and the trachea, sir. If there is any resistance in between, that is there is a shift in the trachea towards the cells.
Okay. So no palpable nodes. Sure about this?
Yes, sir. No palpable nodes, sir. Sure, sir.
Okay. Right. Move on.
Where did you look for the palpable nodes there?
Sir, I examined all the cervical lymph nodes.
Okay. You should tell no other swellings in the neck,
Yes, sir.
not palpable nodes.
Okay, sir.
When you come for discussion, then you should tell that it's the nodes, whatever you felt.
Okay, sir.
If it is a lymph node.
Okay, sir.
Right. So systemic examination is essentially normal.
Yes, sir. So to summarize, 18 years, male complaints of painless swelling in the left side of the neck since 3 months, with a recent increase in the size in the past 1 month. On examination, a swelling of size 7 into 5 centimeters in the anterior triangle of the neck, extending posteriorly with a smooth surface, firm in consistency, without any palpable cervical lymph.
Okay. So what is your diagnosis?
Sir,
Hey, when you say summary like this, without
sir.
palpable cervical lymph nodes, that means the swelling is not the lymph nodes according to you. Go to the summary. Is 7/5 swelling anterior triangle of the neck, smooth surface, firm in consistency, without cervical lymph node means what?
So this swelling is definitely not
That means the swelling is not cervical lymph node.
cervical lymph nodes. Is that what you are saying?
Sir, actually, other cervical lymph nodes, no other.
No other
Yes,
palpable
Palpable
cervical
cervical.
lymph nodes.
You should tell no other swellings.
No other
Okay.
swellings, preferably.
Okay, sir.
Otherwise, you'll get caught. Okay.
You
What
have
is your
mentioned anterior triangle of the neck. You know the boundaries of the anterior triangle.
Yes, sir.
Yeah,
Okay.
tell us. What is the boundary of anterior triangle? What are the boundaries?
Sir, anterior triangle, sir, imaginary lines are at the midline and the anterior border of the sternocleidomastoid, sir. The posterior, laterally and superiorly from the mandible and inferiorly till the suprasternal knot, sir.
Okay. Right. So what is the differential diagnosis? Anybody who wants to ask any questions, any doubts or any clarifications on the clinical findings so far? Sriram, Aishwarya,
Hey, what is your anatomical diagnosis?
Sir, my first anatomical diagnosis is cervical lymph node, sir.
Cervical lymph node swelling.
Yes, sir.
When you got a cervical lymph node swelling with smooth surface, what you should do?
Sir, I didn't get the questions.
Cervical lymph, that is a cervical lymph node, no?
Yes, sir.
So when you have palpated a cervical lymph node, did you look for other lymph nodes in other parts of the body other than neck? Your
Yes.
diagnosis is Hodgkin's lymphoma, no? Second one.
Yes, sir.
Then
What he has done, Srikanth, which I think is wrong, is in the general physical examination, he said there is no generalized lymphadenopathy, but that may be relevant, okay for other general physical examination. But when you're specifically talking about lymph node mass, you should specifically say no palpable axillary, mediastinal, and mediastinal you can't palpate, of course. No palpable or no enlarged lymph nodes in the axillary,
axillary,
mediastinal,
para-aortic region, inguinal
para-aortic,
region,
and inguinal, and also supratrochlear and popliteal.
when you're
You should
suspecting
mention
lymphoma, you should tell hepatosplenomegaly.
hepatosplenomegaly also.
Okay, sir.
That you can't say I have already said that in general examination. You
Okay,
have to
sir.
specifically mention the no palpable, inguinal,
Axillary.
abdominal, mediastinal, and axillary lymphadenopathy. You can even go to say supratrochlear and popliteal.
Okay, sir.
Okay. So your differential diagnosis is cervical lymphadenopathy, and so again lymphoma is also cervical lymph node only. How can
Yes.
they have differential diagnosis like that? Are you considering anything else? Is there any other site of origin from the?
Sir,
Sriram, he mentioned the auscultation findings as normal. So specifically, you could have said there is no evidence of pleural effusion, but he's mentioned the examination is normal. Okay. So cervical lymphadenopathy is also lymph node mass. Lymphoma is also lymph node mass. Anything else in that region which you think it may be?
sir, lateral aberrant thyroid, sir, any unknown
Lateral aberrant thyroid. Okay. Then
and
what else?
metastasis from unknown primary to cervical lymph nodes.
But you are saying it is smooth and firm in consistency. Metastatic nodes will be what?
Hard, sir. Hard.
Hard, and there will be irregular.
Irregular.
Won't be smooth.
Okay, sir.
What else? Aishwarya is saying schwannoma. Why can't it be a nerve, a schwannoma or a nerve cell tumor?
Okay, sir.
Not okay. You have to tell me why you should think of it, or
Why it can be schwannoma or why it cannot be schwannoma.
schwannoma. You can't say okay, sir, for everything.
Sir, schwannoma here the swelling is firm in consistency, sir. So
So what is schwannoma then? Will it be soft or hard? Schwannoma can also be firm in consistency.
firm in consistency, sir. That's what, sir.
So and then the surface will be smooth.
So another
So why
differential. should be.
You have to consider a schwannoma as one of the differential
No, no,
diagnoses.
no. What will be the mobility in schwannoma, man?
Sir, it is horizontally mobile, sir, but vertically mobility won't be there.
Correct. Here there is no mobility
No
both directions,
mobility.
so you cannot
Yes, sir.
consider schwannoma.
Yes, sir.
You cannot consider any nerve sheath tumors.
Okay, sir.
Unless it is fixed already. But
What
then
are the
if
characters of TB cervical lymphadenopathy? Clinical finding.
you have said TB, can you get TB cervical lymphadenopathy like this?
No, sir.
What do you find?
No,
how will
sir,
you-
ಅಂತ ಹೇಳ್ತೀಯ ನೀನೇ ಹಾಕಿದೆಯಲ್ಲಪ್ಪ first.
First diagnosis you said, but it is according to you, a firm, smooth surface mass which is fixed. It is not mobile, it is
Yes, sir.
smooth, it is firm in consistency. So will that be tuberculosis?
No, sir. Cervical lymphadenopathy, sir, actually. So in India, the most commonly
What will be the surface in Cox lymphadenopathy? How the mass is formed?
sir, any
Matting, no, matting of
Ah.
lymph nodes.
Yes,
A matting of the lymph nodes, what will be the surface?
no, sir.
Nodular or
Lobular, sir.
irregular nodular surface, no?
Yes, sir.
If they are very big nodes, you can even call it bosselated, but they won't be so big, I think. So nodular surface,
Lobular, sir. Yes, sir.
irregular and nodular surface. In lymphoma, what will be the surface?
Sir, lymphoma smooth and
See, whenever there is a lymph node swelling, you cannot tell it is a smooth surface at all.
okay.
Because the mass is formed by multiple lymph nodes.
Multiple nodes.
When multiple nodes are there, how can the surface be smooth?
Okay, sir.
Has anyone examined along with you?
So
Sir,
this was a patient taken in Kidwai. So that is why none of us have been able to examine.
The other student, we have gone alone.
He's gone. Now we can't send two people at the same time. Ade problem.
Okay.
Irade ibro. So and then
Correct.
Kidwai will not take two students at the same time.
Oh, you are
ಅದಕ್ಕೆ
posted as a
ಒಬ್ರು-
Kidwai, huh?
ಒಬ್ಬರಿಗೊಬ್ಬರಿಗೆ
Okay,
ಕಳ್ಸಿ.
okay.
Anybody?
When there are such cases, evening you should go along with another student and examine. After 4 p.m.
Aishwarya, what other differential diagnosis would you give? You mentioned schwannoma, but then schwannoma, Dr. Srikanth says, which rightly that it cannot be a fixed swelling. It will be mobile along the axis of the nerve, right?
Yes, sir.
So if you said schwannoma, how will you justify your diagnosis?
Yes, sir. If mobility was there, we could have thought of. for
Yeah,
sure.
but if at all now in the same case, there is no mobility, and then the swelling becomes less prominent on putting the sternomastoid into contraction. So what would that signify for you? It is immobile and becomes less prominent on putting the sternomastoid into contraction. So you may still be right if it is a schwannoma, if it is already infiltrating the under surface of the muscle
Muscle.
and the sheath.
Yes, sir.
Then it may become
Immobile.
immobile, and also it will be, the surface will be smooth.
Yes, sir. So can we think of carotid body tumor?
No. Carotid body tumor will
Carotid
never
body tumor arises from where?
much higher.
Yes, sir.
So, and then also it will never grow to this size.
Yes, sir.
And it's not that common in this age group. And also it would be, there will be, at least transmitted pulsations, no?
Yes, sir. Yes, sir.
So you can't think of carotid body tumor. Please do
Yes.
not give such differential diagnosis. What will happen is people, I would think that, no, I will think very less of you if you give differential diagnosis which are implausible. Okay?
Yes, sir.
It should be close to what your clinical findings are.
Yes, sir.
Sriram, what would you give as differential diagnosis?
Ram is PG, huh?
Yes, sir, from St. Philomena's.
Okay.
Right, Sriram? What are the differential diagnoses you would consider?
Sir, it is not becoming prominent on as per the findings, so it can be a rarely a lipoma also.
Very good.
Okay, lipoma, okay, that's good.
And any tumor arising from the sternocleidomastoid, sir.
What tumor arises from sternomastoid?
Lipoma, what is the consistency?
So usually soft to firm in consistencies.
Why you should get firm?
There is answer to that, Sriram. You can answer. How
Not
will
sure.
it become firm?
Any hemorrhage and degeneration.
It should become more prominent on putting the patient muscle into contraction, no? It is lipoma.
Yes, sir. Yes.
And it is soft, it should be soft in consistency, so that
Yes.
If it is a combination of fibrolipoma
Okay.
or a neurolipoma, it can be firm in consistency, but again, it will be
lipoma will not grow to such a huge size in 3 months.
size in 3
Okay.
months,
Okay.
unless the history is wrong. You cannot usually, blame the patient's inconsistency in terms of the history, because ultimately it is you should be clever enough to get the right history from the patient, even given the fact the patient may not be very intelligent. So never blame the patient for inconsistencies in history. Okay, it's very important.
Okay.
Right. Now, how will you investigate this patient, man?
Sir, first I would like to do ultrasound next, sir, with guided FNAC, sir.
See, you should say investigations directed at ascertaining the nature and the site of origin of the tumor. Investigation directed at confirming the diagnosis, then investigations to assess the general fitness of the patient. This is how you have to classify your investigations.
Okay, sir.
Okay. See, you should answer in a organized manner. Examiner will feel happy that you have put in, thought process into how to answer the questions, not just blurt out something. Okay. So what kind of ultrasound will you do, and what will you glean out of ultrasound scan?
Sir, high resolution ultrasound scan.
Not high resolution. All ultrasound scans now you get are very high resolution only. So what is that specific word? I have just talked
don't
about.
waste the exam, don't waste the time. If you don't know, please say don't know,
Say
so that
don't
they
know.
will go to other questions.
I actually spoke about this in the last class.
Otherwise, you will be around that question only. Ultimately, they will fail you.
Anybody else?
Because everyone will not be knowing everything. So if you don't know, don't know, proceed to the
Don't
next
know.
question.
Anybody
High
else? What?
frequency ultrasound, sir.
High frequency 7.5 megahertz probe, high frequency ultrasound scan. Okay. Right. So what information would you like to get from ultrasound?
Sir, first site of the swelling, sir.
Okay.
And whether the swelling is solid or cystic or any mixed component is there, we can assess through the ultrasound, sir.
Okay.
And any vascularity is
correct. You know the vascularity. Yeah. How will you know the vascularity?
Sir,
initially there may be prominent vessels in and around the swelling. which the ultrasound will pick up. Then you can do a color Doppler, no? You do the
Yes,
color
sir.
Doppler, it will tell you whether it's a vascular swelling or not. Okay.
And surrounding lymph nodes, sir. Any lymph nodes are there?
Okay. Lymph nodes.
And any adjacent structures, sir, and involving any adjacent structures.
That
Uh,
can you, if it is obvious on ultrasound, it may tell it. But
Yes,
will
sir.
it rule out?
No, sir.
What investigation would you like to do to actually look at the nature of the swelling and also its relation to the adjacent structures?
Sir, CT neck, sir. CT neck.
CECT of the neck. Yeah, that
Yes.
is much better investigation to look at the
Involvement
relationship to the adjacent
of
structures.
adjacent structures.
Okay. So ultrasound, so the size of the swelling, origin possibly,
And
and extent of the swelling, echogenicity, whether it is hypoechoic, hyperechoic, and also whether there is solid and cystic components or mixed components, and vascularity, presence of or absence of lymph nodes.
lymph nodes.
These are all the information. Srikanth, anything to add?
Nothing. MRI is not necessary at this stage.
MRI is
If your tissue
probably,
diagnosis gives malignancy, then you should go for MRI.
yeah. So you have done ultrasound. What else will you do? Pavan?
Sir, as I said, no, sir, if there is any involvement of surrounding structures, I would like to go for to know the involvement of surrounding structures, CECT next.
No. CCT is
Bro,
later.
you have done an ultrasound, you have got the finding. What will you do next?
What will you do next? Not CCT.
Sir, to confirm the diagnosis, I would like to go for FNAC, sir.
Correct. So FNAC. So FNAC is done directly, or do you think you should get a ultrasound guided FNAC?
Sir, USG guided ultrasound we have to do.
Not necessarily always. See, this is an obvious swelling, right? It's not. And to you, as far as you are concerned, it is uniformly firm, right? There is no difference in the consistency of the swelling.
Yes, sir.
When it's not variable consistency as far as clinical examination is concerned.
Yes, sir.
So unless the ultrasound shows a particular area which is solid or mixed echogenicity or of sort of suspicious area, you can go for a direct FNAC. If these findings are there on ultrasound, then you go for an ultrasound guided FNAC.
FNAC.
Understood?
Understood.
Yeah. Okay.
So can we consider true cut biopsy?
True cut biopsy.
True-cut biopsy is not indicated in lymph nodes.
On this, and also, there are very vital structures. If at all you hit any vessel or something, you'll have severe bleeding. So, true cut biopsy in the neck is not indicated, ma.
Okay.
Okay.
What is the FNAC finding?
Sir, they done the biopsy, sir, so showing a spindle cell neoplasms.
Spindle cell neoplasm.
Oh, they have done. This is open biopsy, man. They have done. What is that? It's the report.
That's why they have done HPE.
Yeah.
Histopathology, not FNAC. That you said it's a FNAC a scar.
FNAC probably it is inconclusive, so they have gone for
If it's
incision
not an
biopsy.
FNAC scar, if it is it's a
Incisional biopsy.
incision biopsy. Okay. Right. What you have the ultrasound report with you?
Sir, ultrasound not done, sir. Actually,
What did they do?
Directly they done the CECT next.
Okay, put up the CT report.
Sir, here there is a evident large, fairly defined homogeneous enhancing soft tissue density lesion noted the left pre and paravertebral region of
The
the
pre
neck.
and paravertebral region means it is deep to sternomastoid.
Okay, sir.
And it's fairly big. It's much bigger than what you said. 8 into 7 into 10, 11 centimeters.
Yes, sir. and superiorly extending along the left paravertebral region till the level of the lower border of the C4 vertebra, sir, and inferiorly extending into the superior and posterior mediastinum till the level of the lower border of the D3 vertebra, sir. And finally, they gave impression that a large, fairly defined, homogeneously enhancing lesion with necrosis in the posterior mediastinum in the left side, extending to the lower neck, as described like a suggestive of a small round cell tumor. Differential diagnosis: soft tissue sarcoma and HB correlations.
Okay, so it is a spindle cell tumor on histology,
Yes,
and
sir.
a large mass in the neck extending into the mediastinum.
Yes, sir.
Okay, so now what will you do with this patient? You got the histology, you got this. Would you like to do an MR in this patient?
Sir, actually, to know the better regarding the soft tissue like vessel involvement is there, we can go for MRIs. And as Srikanth sir said, if it is a neoplasm, like a spindle cell neoplasm, we want to know about the surrounding related structures, whether infiltrated or not.
That CT will give you the same information, no? What does MR? What is the superiority of MR?
So it gives more information regarding the soft tissues.
Correct. Soft tissue relation of the tumor, it gives you better. What is the superiority of CT?
Sir, it gives more information regarding the bone.
Bony involvement.
Bony involvement.
So, because it is close to the paravertebral area, it will give you better information about the whether transverse process and the bone is involved or not.
Yes, sir.
Okay. Right. So now you have a large tumor, 8 into 7 into 11 centimeters,
Yes, sir.
extending in close relation to the subclavian artery, right?
Yes, sir.
And compressing the subclavian artery and with narrowing of the subclavian artery. So you should have mentioned whether there is any difference in the pulse. The two, you said there is no difference in the pulse,
No
so we
difference.
probably take it in that way. And now it is displacing the trachea and also compressing the trachea. There is a slight narrowing, luminal narrowing of the trachea.
Yes,
now you got the histology, spindle cell tumor. So what is your diagnosis now?
Sir, spindle cell neoplasm abutting the surrounding structures, sir, like.
So what is where does spindle cell neoplasm fall into? Which category?
From the,
You don't know.
I don't know, sir, exactly.
Anybody else? Spindle cell tumor? Tanya?
The kind of stuff.
So does it come under soft tissue sarcoma?
Soft tissue, sir.
It comes under, yes, soft tissue sarcomas. Sriram?
No, soft tissue, sir.
Indraja?
So soft tissue sarcoma.
Are you sure, or you're all a bit hesitant?
It will come under soft tissue sarcoma only.
Okay, it does come under soft tissue sarcoma. So now, soft tissue sarcoma, spindle cell neoplasm. So now you have all the information. So what grade of the tumor is it? What is the class? I think now the N.A. King classification is not applied. There is a new classification for soft tissue tumors. So where will this stand? It is beyond 10 centimeters, right?
Yes, sir. T4, yes, sir.
Oh, Guru, spindle cell neoplasm, you are telling it is a soft tissue tumor.
Yes, sir.
For soft tissue tumor, do you use TNM classification?
It's not TNM, man. There is a
Before giving you staging, what you should do? In a neoplasm. When you have got a tissue diagnosis, what is the next step?
Sir, metastasis workup, sir.
How does soft tissue neoplasm spread?
Sir, sarcomas spread through hematogenous.
hematogenous spread, no?
Hematogenous spread, sir. Yes, sir.
What are the investigations you have to do?
Sir, sir, see chest X-ray and
Not
CT,
just X-ray, man.
CT chest and abdomen, sir.
Hmm.
And
See, it is
There is already a finding in the this thing lung. They have done an MRI or CT something, no?
CT that answer.
No, there is a finding in the lung. You have not read, huh? CT.
Go to the next page.
Go down, or next slide. Huh?
See, they have said
Obvious lung nodules or parenchymal changes noted in the bilateral.
I think considering that this is a very large
See, they are
tumor,
written, no, tiny subcentric nodule in the anterior segment of right lobe. Suspicious.
so
Yes.
what will you do? Because it's a large tumor, it is again very almost infiltrating the subclavian artery. Then there are subcentimeter lymph nodes along the neck, along the right
Upper
upper
lobe.
lobe of the lung.
Yes.
So does this, all these signs, do they make it resectable?
No, sir.
So what will you do?
Sir, chemotherapy with the chemo radius.
No, first investigation wise, do you want to show that is the disease confined to whatever they have described in the CT, or are there distant metastasis?
Sir,
What is the role of PET CT in here?
PET CT, yes, sir.
You should do a PET CT.
PET CT, yes, sir.
It may not be a primary mode of investigation, but once you have had a CT finding like this, when it is bordering on non-resectable tumor, it can be resected if you have, vascular surgeon and all those things. But you should, if at all, let us say there is bony mets elsewhere or cerebral metastasis, then you can't undertake a very major resection.
Yes, sir.
Because it then,
How do you stage soft tissue tumors?
What classification do you use for soft tissue tumors?
Staging.
Staging.
Sir,
Previously, it used to be called King classification.
yes.
But I don't think it is King now. Tanya, you just passed recently.
Sir, I'm not sure, sir.
Not sure. Sriram, Aishwarya, Indraja, any of you?
There is an TNM classification
TNM.
also now for AJCC classification for head and neck soft tissue.
It is no longer called all the soft tissue tumors used to be classified by as King classification, ENNEKING, King. But now I don't think they use that. So the homework for all of you guys is to find out what is the latest staging of soft tissue tumors.
You type the staging, stick on to the wall of your room, and then read once in a week.
Okay.
Okay,
Okay.
right.
Yes, okay.
So you have to know what is the staging. I think it's 10
If the tumor has not spread anywhere, what is the treatment?
What is the treatment if the tumor is confined to certain muscle planes?
Sir, a resection with 1 centimeter margins.
No, I think soft tissue tumors, I don't think you give centimeter margin and all that. You have to, in the neck, I don't know, but compartmental excision, you have to remove one compartment above the where you are suspecting the tumor. So that is that. I think what we'll do is 10 o'clock now. So you have dragged on the case by not being sure of the.
What treatment they have done in Kidwai?
Sir, actually not yet done, sir. The patient, what they planned is left a radical neck dissection with sternotomy, with the clearance.
Mediastinal resection, yeah.
Yes, sir. Mediastinal
Followed
resection.
by RT.
Yes, sir. RT and all not mentioned, sir. So a sternotomy they mentioned, sir.
Yeah, mediastinal mass also they have to remove.
Yes, sir.
Usually it is excision followed by radiotherapy if there is no distant metastasis.
Sir, in some literatures, so radiotherapy is useful and some literature said, and in some literature,
No. No, it depends on what is the site of origin. For
Okay, sir.
example, whether if it is rhabdomyosarcomas and this one synovial cell sarcomas, they also spread by lymph nodes. All sarcomas spread hematogenously. So that
Yes.
is a given. But there are certain soft tissue tumors, rhabdomyosarcoma and synovial cell sarcoma. They have a 10 to 15% chance of spreading by lymph nodes also. So that is another point for you to consider.
There are multiple subcentric lymph nodes they are mentioned.
Yeah. So I think, and then the tumors, some of the tumors are radiosensitive, some of the tumors are chemosensitive. So we should know what tumors are likely to be radio and what to be chemo sensitive. You have to find out what this spindles.
IHC is useful, sir. Here,
Huh?
right?
That's what immunohistochemistry, spindle cell tumor.
Yes, sir.
You have to find out whether it is chemo or radiosensitive. So what we will do is, now we have come to this discussion. It's 10 o'clock already. So I want you to go back and go through the current staging of the soft tissue tumors,
Okay,
generally and also specifically in the neck, and then we'll discuss the treatment options in the next class.
Okay, sir.
Okay.
Whose unit is this?
Sir, this is first unit, sir. Ravi Arjun, sir.
Ravi Arjunan.
Yes, sir.
You present this to them, man.
Present it, see whether you catch hold of one of the at least lecturers or assistant
Present
professors.
Ravi Arjunan.
He is actually quite good.
Who else is there in his unit? Srinivasa?
Sir, Ravi Arjunan, sir. I don't know names of the assistants, sir.
Yeah, you go and tell them. I'll present the case anta.
Yes, sir. Sir, I discussed with the PG, sir, regarding this.
Yeah, present to PG only. You read and go and present. Better present to PG.
So what did they say?
Sir, findings what I mentioned, no, sir, the plane of the swelling, I had a doubt, sir. They said it is deep to deep fascia only, and it is immobile, sir.
Not deep to deep, it's deep to sternomastoid, man. Because it's a lateral mass, no?
Yes, sir.
It's not midline. It is coming from laterally towards midline. It is 6 centimeter, according to you, 6 centimeter from midline.
Yes, sir.
So you can't, where is we keep on saying there is no deep fascia is there, but it is split and invests the sternomastoid, no?
Sorry, it's only a potential space, that's all.
So it is deep to sternomastoid muscle.
Okay, sir.
So what we will do is next class, you know the staging, the classification, treatment. Okay.
Okay,
It's already 10 o'clock. So there's no point carrying on because we won't finish it in next 5 minutes. And I think all of our, this attention span is only 40 minutes at the most. So we have already gone beyond that. Okay. So any questions so far? Anybody? Tanya, how do you think he presented?
you are doing a clinical diagnosis of lymph nodes, don't tell surface smooth.
Okay, sir.
Now you know what happened.
Srikanth, your impression was how you presented?
Okay, has to improve. Still, no, you have to read Das thoroughly. Still,
Okay, sir.
there should be no interruption when you are presenting. Examiner should not interrupt when you are present
Interrupt you
or
when
the
you present.
diagnosis.
As I
By
told
heart,
you,
Das.
okay. Sanya,
Okay, sir.
Sanya, are you there?
Yes, sir. Yes, sir. Yes.
Anya, I thought you want to play
What?
tennis.
Hello.
What is your impression on his presentation today?
Sir,
Be
he
truthful.
did make a few, yeah, sir, he did make few basic mistakes, sir, in the examination part. He used to be
Okay.
very careful about those, sir.
Specifically, I think, basically so if you
The
say
trachea shifting sign
surface
and
plane of
palpation
the
of,
swelling, yeah,
yes, sir, all those as well as those examinations of trachea and carotid pulses. Now they're frequently done in the thyroid cases, sir, and we've discussed a lot of thyroid cases.
so you should not make mistakes in that, man, Pavan. You are saying C7 for carotid, and you didn't know the method of examination for tracheal deviation. Okay, so we will discuss the staging and management of this patient go through chemotherapy. We can even invite the Swaroop for that class, and then we'll discuss that. Okay.
Okay.
Okay. So I think Srikanth has told you what are the mistakes that you made. Improve your presentation and be more thorough. Okay. Right. Good night. Good night, everybody.
Thank you.